In this presentation, an intra-articular fracture of the distal radius will be treated with a double plate fixation. The plates used are 2.4 variable angle LCP distal radius plates, one 2-column Volar plate, and one intermediate column dorsal plate. The objectives of this exercise are to identify the clinical indications for double plate fixation and pre-operative planning, to show the principles of the variable angle locking system, the patient position and the approach, the instruments needed, the approach on the bone model, and the reduction and fixation of the fracture. The indications for combined Palmar and dorsal approaches are a hyperextended Palmar fragment and/or loss of Palmar buttress, combined with impacted articular fragments, a displaced dorso-ulnar fragment, and/or associated carpal ligament tears. Be aware that through a Palmar approach, visualization of the joint surface is not possible, as opening of the capsule would lead to some carpal instability. A formal arthrotomy through a dorsal approach allows visualization of the joint and the proximal carpal row. Here is an example of a complex distal radius fracture caused by axial compression and shear forces. In the CT, it can be seen that the Palmar articular fragment is hyperextended and has no contact to the Palmar cortex, so it must be first reduced and buttressed with a plate. On the dorsal side, the dorsal ulnar fragment is displaced, and there is an impacted central articular fragment of the intermediate column. These fragments must be directly reduced and fixed with a plate. The variable angle locking screw and the standard locking screw are shown. The head of the variable angle locking screw has a rounded shape, whereas the head of the standard locking screw has a conical shape. The design of the plate hole in the head of the plate allows the variable angle locking screw to be inserted up to 15 degrees off-axis in all directions. The variable angle locking screw can also be inserted at a fixed angle into the threaded portion of the combi plate holes. The standard locking screw can only be inserted at a fixed angle and only in the threaded portion of the combi plate holes. To drill off-axis holes at the desired angle, the funnel-shaped end of the universal variable angle locking drill guide is used. The drill guide tip is inserted coaxially into the cloverleaf design of the plate hole. The tip of the drill guide must remain fully seated in the plate hole while drilling. The funnel of the drill guide allows the angle of the 1.8 mm drill bit to be varied as much as 30 degrees. The fixed angle end of the drill guide only allows the drill bit to follow the nominal trajectory of the locking hole. The plate is available in a left and right version. The instruments needed to insert cortex screws are the 2.4 universal drill guide, the 1.8 mm drill bit, the depth gauge, and the short T8 star drive screwdriver shaft and handle. The instruments needed to insert the locking screws are the threaded 2.4 LCP drill sleeve, the 2.4 universal variable angle LCP drill sleeve, the 1.8 mm drill bit, the short T8 star drive screwdriver shaft, and the 0.8 Newton-meter torque limiting attachment with handle. The 1.25 mm plate reduction wire with small stop is useful to hold the plate in position on the bone. The model is placed as shown. The landmarks are the radial styloid and the radial artery of the flexor carpi radialis tendon. A longitudinal incision is made slightly radial to the flexor carpi radialis tendon. The dissection is made between the flexor carpi radialis and the radial artery, exposing the pronator quadratus. The pronator quadratus is detached from the lateral board of the radius and elevated towards the ulna. For the model, a second retractor can be helpful. The fracture is reduced using the preferred reduction technique. The reduction technique will be fracture-specific. The plate is positioned on the extraarticular Palmar surface to judge the position of the plate relative to the distal fragment. The first screw to be inserted is a cortex screw applied through the elongated hole in the plate shaft to allow a later adjustment of the plate. The 1.8 mm drill bit is used for a 2.4 mm locking or cortex screw. The 2 mm drill bit would be used for a 2.7 mm cortex screw. The depth is measured with the depth gauge. A 2.4 mm cortex screw is inserted with the T8 star drive screwdriver. The plate position should be checked under image intensification. The plate position is adjusted if necessary and the screw is retightened. The anatomically pre-contoured plate is used as a reduction template. The articular block is reduced to the plate using either direct pressure or a dorsally placed pad and temporarily fixed in place by two 1.25 mm K-wires. If necessary, 1.25 mm plate reduction wires can be inserted through selected K-wire holes in the plate to temporarily fix the plate distally. The threaded 2.4 LCP drill sleeve is screwed into the most proximal plate hole and a 1.8 mm hole is drilled. The depth of the hole can be read off the scale on the sleeve and the mark on the drill. The drill sleeve is removed and a 2.4 mm locking screw of appropriate length is inserted using the short T8 star drive screwdriver shaft and the 0.8 Nm torque limiting attachment with handle. To drill off-axis holes at the appropriate angle, the funnel-shaped end of the universal variable angle locking drill guide is used. The funnel allows the angle of the 1.8 mm drill bit to be varied as much as 30 degrees. In this fracture pattern, short screws are used to only fix the Palmar ulnar fragment as the dorso-ulnar fragment is not yet reduced, so 10 mm long screws are used. The appropriate length locking screw is introduced. To insert a variable angle locking screw at a fixed angle, the 1.8 mm drill bit is used with the fixed angle end of the drill guide. This end of the drill guide only allows the drill bit to follow the trajectory of the locking hole. The depth of the hole can be read directly from the mark on the drill and the scale on the drill guide. 10 mm. The appropriate locking screw is inserted. In order to fix the radial styloid, the most radial screws should be directed distally and radially as needed. The remaining plate holes in the head of the plate are filled as necessary, either at a variable or a fixed angle. The reduction forceps and the K-wires are now removed. At this stage, it is important to check the reduction and the placement of the plate under image intensification before continuing with dorsal plate fixation. For the dorsal plating, the intermediate column is fixed with a 2.4 variable angle LCP dorsal intermediate column distal radius plate. If contouring should be necessary, undercuts and bending notches allow easy contouring while preserving the variable angle locking holes. The funnel-shaped end of the variable angle LCP drill sleeve allows the drilling of variable angle holes at the desired angle. The fixed angle end of the variable angle LCP drill sleeve only allows the drill bit to follow the nominal trajectory of the variable angle locking holes. The instruments needed for the dorsal plating are the threaded 2.4 LCP drill sleeve, the 2.4 universal variable angle LCP drill sleeve, the 1.8 mm drill bit, the short T8 star drive screwdriver shaft, and the 0.8 Newton-meter torque limiting attachment with handle. The 1.25 mm plate reduction wire with small stop is useful to hold the plate in position on the bone. For the dorsal approach, the model is placed as shown. The styloid process is palpated along with Lister's tubercle. A straight incision is made. A L-shaped incision of the retinaculum is made along the extensor pollicis tendon. The retinaculum and the subcutaneous tissue are retracted. The intermediate column is approached by subperiosteal preparation. The tendons of the fourth compartment are retracted. A transverse arthrotomy is performed to allow visualization of the joint and the proximal carpal row. The dorso-ulnar fragment is still displaced and mobile, while the radial column is reduced and fixed in position by the Palmar plate. This is the metaphyseal defect. The dorso-ulnar fragment is reduced to the radial column. The reduction is secured with a large pointed reduction forceps. Any step-off should be corrected now. The dorso-ulnar fragment is held in place temporarily with a K-wire. The intermediate column plate is applied first. The correct position is determined. The 1.25 mm plate reduction wire with small stop is used to hold the plate in position on the bone. The fixed angle end of the variable angle LCP drill sleeve is inserted into the second most proximal plate hole. The 1.8 mm drill bit is used to make the screw hole. The hole follows the nominal trajectory of the variable angle plate hole. The depth can be read off the scale on the drill sleeve and the mark on the drill. The appropriate length locking screw is inserted and fully tightened with the 0.8 Nm torque limiting attachment. The plate reduction wire is removed. A locking screw is inserted into the most proximal plate hole using the nominal angle technique and fully tightened. The funnel-shaped end of the variable angle LCP drill sleeve is inserted into one of the plate holes in the distal arm of the plate. A hole is prepared with the 1.8 mm drill bit at the desired angle. After measuring the depth, a locking screw of appropriate length is inserted and fully tightened. A second locking screw is inserted into the arm of the plate. The reduction forceps and the K-wire is removed. Here is the completed fixation. The intra- and post-operative X-rays show good reconstruction of the joint surface and correct placement of the implants. This presentation has demonstrated the clinical indications for double plate fixation and pre-operative planning, the principles of the variable angle locking system, the patient position and the approach, the instruments needed, the approach on the bone model, and the reduction and fixation of the fracture.